Alright guys, now in this video I am quickly going to cover the important topic of papilledema. Now papilledema is bilateral disc edema. Mind you, if one eye is having disc edema, you will not say it papilledema because papilledema etiology is the central cause, raised intracranial pressure. Yes, okay. Now if I talk about the etiology, what are the causes that may lead to raised intracranial pressure? One is infections like meningitis. That is why whenever there is a case of meningitis and they need to require the CSF examination, they always call an ophthalmologist to look out for disc edema. If there is disc edema, that actually tells the doctors, the internal medicine specialists who are going to do lumbar puncture, that boss, the intracranial pressure is raised, and then if they will try to pull up CSF via lumbar puncture, so it may become uncontrolled and the patient may go into ICU by doing lumbar puncture. So they always call an ophthalmologist. Yes. Second, there can be benign intracranial hypertension. Benign intracranial hypertension is associated with the females 1F who are for more than or equal to 40 years of age, second F, and who are fat. How fat? What is the age? Usually more than equal to 120 kgs. They are more prone to develop papilledema. All right. Now coming over to the third important etiology is ICSOL, intracranial space occupying lesion. In other words, trauma. No, not trauma. In other words, tumor. Yes. जैसे कि टाई को हम क्या बोलते हैं? कंठ लंगोट. वैसे intracranial space occupying lesion looks like a very fancy word. It is actually tumor. Any brain tumor. Done? Okay. Now coming on to pathogenesis. When there is raised intracranial pressure, it is going to compress upon the optic nerve and it leads to stasis of exoplasmic outflow, which starts getting collected at the head of the optic nerve, which is seen by an ophthalmologist in a form of optic nerve head or optic disc edema. Papilledema, both eyes, bilateral. Yes, all right. So what will be the clinical features? So because I told you that the main cause is raised intracranial pressure, so the patient will typically complain of headache. That will be occipital headache and it will be posture independent. It will not be dependent upon the posture. Posture independent. Occipital headache. Now there is typical vomiting. You must have read in your medicine that vomiting is your projectile vomiting which is present. Which is the earliest sign? Earliest sign is dilated and tortuous vessels. Dilated and tortuous vessels. We are talking of veins here because veins take the blood from retina to ultimately into the cavernous sinus, because there are veins which will form central retinal vein. Central retinal vein will ultimately drain into your cavernous sinus. Yes. So if there is raised intracranial pressure, it is going to compress the veins which are bringing the blood from the eye. Which are those two veins? Superior ophthalmic vein, inferior ophthalmic vein. Yes, when it will get compressed due to back pressure, the central retinal vein will also have dilatation, and in the end you can actually look out for the dilatation of veins in the retina by doing fundus examination. So one is this. Second is loss of pulsation. Loss of, again, venous pulsation. All right. Now, what is transient visual loss? In cases of papilledema, the patient may have a very short attacks of sudden loss of vision. So that is known as amaurosis fugax. This is your previous year question. Now coming over to the signs which you are going to see on fundus examination typically. So I am going to show you the image so you can appreciate here. So can you appreciate that the disc margins are non-defined? So in other words, you can say that the margins are blurred. You can actually appreciate here that there is a flame shaped hemorrhage. You call it as peripapillary hemorrhages, and these are present on the superficial nerve fiber layer, just around the optic nerve head. That is why it is called peripapillary hemorrhages. Here can you also appreciate, along with peripapillary hemorrhages, the bulging disc? This bulging disc that you see in papilledema is champagne cork appearance of the optic nerve head. And of course, dilated and tortuous vessels. You can see veins, yes, dilated and tortuous, and you are also going to appreciate the loss of venous pulsation. Now, typically, the important point you should know, vision is not affected till late. So, unless it leads to secondary optic atrophy, only then the vision will be affected. So, it is not affected. Number one. Second important point, that no RAPD. Third important point, that there is no dyschromatopsia. Dyschromatopsia is red green color deficiency. You know na, if there is involvement of the macula, the patient will have difficulty in blue and yellow vision. If the patient is having any disease of the optic nerve, the patient will have problem in seeing red and green colors. Now you'll say, sir, in this condition, why you are saying that the patient will not be having dyschromatopsia, since you just said that if there is problem in the optic nerve? Here I'll correct you. It is not a problem of the optic nerve per se. It is actually raised intracranial pressure which is reflecting on the optic nerve. So optic nerve is fine. It is able to take the impulse from the retina to the brain. But due to long-standing papilledema, there can be secondary optic atrophy. Then the patient will have loss of vision, RAPD, and even initial stages, the loss of red or green color. Now, false localizing sign. False localizing sign is when there is raised intracranial tension. So the brain stem is pushed inferiorly, and you know there is one nerve which is coming from the brain stem from the ventral part. So when the brain stem goes inferiorly, there is a stretch in the nerve that develops. Which is that nerve? That nerve, boys and girls, is abducent nerve. Now abducent nerve supplies lateral rectus muscle. So false localizing sign is abduction deficit or abduction defect. Abduction defect, and it is due to involvement of 6th cranial nerve because it arises from pons. Okay, all right. Now coming over to this perimetric image. What is this perimetric image? Can you tell me? Now, all right. Now, this is right and left, and if you would carefully see, you would see that there is enlargement of blind spot. Ideally, blind spot should be this. I told you there is peripapillary edema. When there is peripapillary edema, it is going to involve the peripapillary region of the optic nerve head, whose reflection in the perimetry will be in the form of enlargement of blind spot. This is your INICT last year question. So enlargement of blind spot is seen in papilledema. All right. your previous year question. Here also what you can see, can you appreciate some lines which have been marked with a black arrow? So these are basically retinal stretch lines. These are stretch lines in retina due to collection of fluid, and these lines are typically known as Patton's lines. Now coming over to the management part, how you are going to manage this case. If you know the etiology, you know the treatment, and here the etiology is what? Raised intracranial tension. So first and foremost, you will decrease the intracranial tension by giving oral acetazolamide. Oral acetazolamide, which is a diuretic, it is going to decrease the intracranial pressure. Number one. Now you will say, sir, can we give intravenous mannitol? Mannitol is a sugar alcohol. It is also going to decrease the intracranial tension, but before giving IV mannitol, you have to make sure that there is no hemorrhage, no intracranial hemorrhage. Intracranial hemorrhage will also occupy some space, and it may also lead to raised intracranial tension. Now if you are going to give IV mannitol, it is going to leak through the bleeding vessels intracranially, and due to osmotic effect, it will, allow more and more water to get collected intracranially. It will increase the condition. So before going on for IV mannitol, you have to make sure that there is no hemorrhage which is present. Yes. All right. So this is all about your papilledema. I have covered all the important PYQs in this short video. Now I'll be coming up with more such videos. And yes, as I always say, you can follow me on Telegram. The name of my group is Ophthalmology by Dr. Manish Chhabra. In case of any doubts that you want to have the answers instantly, you can always WhatsApp me on this number. Yes, and I'll try to be as quick as possible in responding to all of you. Best wishes from my side.